Sunil.
Thank you. And good evening, everybody. So we will straight away move on to the second part of the session, the role of palliative care in neurological diseases. And as you know, Dr. Roop Gursahani will again walk us through this session. So, Dr. Roop, you are now familiar to everybody. So, I am not attempting to introduce you again.
Thank you.
So, please continue with your presentation.
Okay. Thank you, Dr. Sunil. Can I share the screen? Yes. So I'm actually seeing, I think at least two people from the neuro course here. So just give me a minute. Right. So thank you, Palliative India, for inviting me again. And today, now, last time we did an overview of what it is that you do in neuropalliative care. So to take it a little further, what I'm going to do is show you some cases from the course that I'm running, and as I see it, a couple of the members definitely from the course are here also. So I'm sorry, there'll be a little bit of repetition there. But I'm again bringing this slide up to tell you that these skills are applicable from diagnosis until death. And it is up to us to apply these skills. So let me start off with the first case. The first case is this lady who was under my care. She had a seizure while out shopping, and she had another seizure when she arrived in the casualty. She had no further seizures after she was given an antiepileptic, and her neurological examination was actually completely normal. Now, this was a scan that was done. Actually, she had a CT scan immediately in the casualty, and this MRI scan was done a little later. But I'm sure it doesn't take any neurological skills to see that there is something extremely sinister here in the right temporal lobe. Right? Now, if you look at CNS tumors, they differ according to age, and they differ according to location. But probably the biggest are the ones that are in big letters here. So in younger childhood, pilocytic astrocytoma and medulloblastoma. But for adults, it is metastatic malignancy, glial tumors, meningioma, and pituitary adenoma. And in fact, this is the benign one, and these two are the ones that kill. So I'm not sure if you are familiar with this, but looking at the shaggy edges and all that, we were reasonably sure that this was a glioblastoma. And you will wonder, what role can palliative care have at this stage? So I'm going to ask you to start putting up your comments in the chat box, because at the end of the case, we will have a discussion. There are, depending on the time, we have 4 cases, and it'll be good if we can make it interactive. So the next morning, her husband and her sister were in the consulting room, and their initial statement is, the first is, what is it? And then second is, whatever it is, we don't want you to tell her. And this is something that is a perennial problem if you're practicing. If you have any bit of palliative care experience, you realize that collusion is something that we are hit with very often. So she actually was a pretty, she was a very accomplished woman. She resigned as a CFO, Chief Financial Officer, and she had set up and joined an NGO. And she and her husband were very close. Two children, both settled abroad. And the younger sister who was there possibly had a bit of psychiatric illness and was kind of in and out throughout the period that I was involved with this case. So, one of the first things that we have to accept, and in when we make a diagnosis like this, is that some of the collusion arises from anticipatory bereavement and loss in the family also. It's difficult for them to accept what is coming up ahead, and they react in the only way they know. So uh, I spoke to them. I kind of understood what they were at. And it was a fairly intense discussion, but um, I was able to uh, convince them that this was not a patient where they could push the diagnosis under the carpet and go on with any kind of treatment. So she went ahead with surgery, and the surgery uh, followed the protocols that are typical for malignant brain tumor. Uh, Under the age of 70, do you actually between and in all ages you do a maximal safe resection, and depending on the facilities, and I think they are now available in most places, you can do it uh, under neuronavigation, so you get out as much as possible of the tumor because that is one of the first things that improves prognosis. And then, depending on whether it is uh, on the age and depending on what you find on histopathology and immunohistochemistry, you decide about various combinations of uh, radiotherapy, temozolomide, and other drugs. And it these decisions really have changed since the advent of immunohistochemistry. Now, her report showed a high-grade glioma with large areas of necrosis, and well, the tumor cells were negative for IDH1, uh, with uh, I mean, in the sense that this is probably the worst prognosis for uh, these tumors. And obviously, the first time I saw her, sometime after the surgery, because after the surgery, we wait for about uh, 3 weeks uh, after the operation, and then they start off with first radiotherapy and then chemotherapy. Now, in these patients, if you have an IDH mutation, um, and if you have these two additional features on immunohistochemistry, you actually identify a reasonably better prognosis. I wouldn't say good, but reasonably better prognosis. Whereas if you identify, as in her case, IDH wild type, then these are very likely to be glioblastoma multiform and will behave as such. And this is to the point that currently the WHO classification actually takes this into account. So IDH wild type is glioblastoma. If there is something called IDH mutant, then it is astrocytoma. And if it is IDH mutant and it has IP and 19q co-deletion, uh, then this is a significantly better prognosis. And we'll see that a little further. So she got post-operative, uh, she got fairly, I mean, she was operated by a top neurosurgeon and everything, as much as possible was taken out. And she did very well in the sense she had no post-operative deficit. After the 3 week recovery period, she started off on fractionated radiotherapy and then went on to chemotherapy and needed steroids during the radiotherapy. Now, as you can imagine, palliative care has a role uh, practically through the course of these patients. And you look at the palliative care and what it can do at various stages. At diagnosis, Now, you ideally give information about the tumor and the treatment. Obviously, the information about the tumor is to some extent depends on uh, what the family is willing to accept and the patient is willing to accept. And you have to be very, very careful about how you frame this. There are two aspects here. One is that this is an individual who's going to lose capacity soon, so you do need to have them understand prognosis. At the same time, uh, a negative prognosis, and this is a kind of situation where a negative prognosis is likely, actually can turn both patient and family away, and then they go out doctor shopping, and then you know how that turns out. So what you have to do is to combine hope with honesty and acknowledge it to them that um, that there is a certain amount of uncertainty, and you also have to acknowledge the fact that you know that your honesty may impact their hope, because this is a kind of a uh, tension within the uh, doctor also, and it has been said that that is useful for the patient and family also to know. Once radiotherapy is over, then you enter a plateau phase, and you have to understand how the tumor is going to affect the patient, and kind of obviously you're keeping in touch. At a fairly early stage, you need to be uh, contacting the caregiver, or meaning establish um, a kind of a communication channel with the caregiver. And perhaps because the caregiver has a fair amount of burden, you will also have to talk to the caregiver about respite. And as as is likely, recurrence occurs, then you start responding to emerging needs, you address expectations, and start preparing for end of life. So uh, towards the end, the caregiver will need information about practical information about resources and so on, and supports. And one of the things is that in neurology, we do not have access to formal hospice care except in this situation, because this is oncology. So these are the patients from our side who can actually access regular hospice care, uh, even in India. So this lady, 3 weeks after her 60th birthday, um, she turned up accompanied by husband, son, sister. The daughter, who was in the US, was expecting a baby, and she had a great 60th birthday party. And the only thing is that she could not really tell people's names. Although this was uh, expected as a part of the radiotherapy, it was still upsetting. And she came in because she had a flurry of seizures. And the seizures were controlled. We'd already given her levetiracetam, we had to add phenytoin, and the tumor had recurred. So this, and when she came in, again, she wanted to know. Her speech was slurred, but her cognitive function was not too bad. 24 is at the cutoff for dementia. So she wanted to know what is wrong with me, how long do I have, and the husband and the sister wanted to know whether we can try other treatments. Now the thing is about this treatment, about this tumor, is that we knew that systemic therapy was unlikely to work too well. So at this point, we have to actually discuss with the patient and family what they would want and who would make these decisions. So, as is usually one of the things that I do, at some stage, I do ask my patients a basic question about their um, spiritual needs, and usually the leading question is, "Are you at peace?" Um, of course, from her side, as I said, her question was, "How long do I have?" And when I spoke about, "Are you at peace?" she said, "My only concern right now is that I want to see my granddaughter." Uh, and she said, "My daughter showed me the sonography pictures and she looks like me." Uh, Obviously, this is something that can happen only in the US. In India, because of the PNDT Act, there is no way that you can uh, get this kind of a report. So, what do we know about prognosis in this situation? Well, in glioblastoma, you can see that a significant proportion will pass away within a fairly short period of time, whereas those who have uh, oligodendroglioma will go on much slower. And this lady obviously was in the category that we expected to have a poor prognosis. Now, remember that during this period, because the caregiver is so heavily overloaded with decisions, with routine care, and also their own knowledge of their impending bereavement, it can become extremely difficult for them, and you have to keep an eye on how things are. When we look at providing palliative care, remember that we try and differentiate between primary, specialty, palliative care. Uh, Remember that all of us, even those of us who are not qualified fully in palliative care, are supposed to provide primary palliative care. Our business is to manage physical symptoms, look at depression and anxiety, and at least begin the discussions, and also recognize the indications for specialty palliative care. Specialty palliative care usually is an interdisciplinary team, but otherwise is somebody who practices only palliative care. And here they come in for management of refractory physical symptoms, uh, sorry, mm, uh, social assessment, spiritual assessment, uh, end of life care, and so on. And this sometimes, uh, as I said, uh, can be provided in a hospice even in India, and of course, uh, can often be done in the patient's home. So, unfortunately, there are barriers, and we know them. The main barrier is that referral to specialty palliative care is usually late. Here, because I was involved, that I think happened on time. So she was started on bevacizumab with the plan of continuing it until terminal neurologic decline, because we even though we knew it was not going to be effective, she still had that goal of meeting her granddaughter, which she did. And she spent 2 months with both her kids. And 15 months after her diagnosis, she finally passed away at home. And we had been able to manage the symptoms reasonably well. So I'm going to stop at this point and take questions for this case and look at the chat. Yes, so uh, quite right, Dr. Punita. Uh, Communicating a diagnosis and the prognosis to her and the family, yes, in some ways, it's not an easy job for us, and we have to acknowledge that part of the barrier is within us. The fact that because it's not easy, we very often take the easy way out and say, okay, we won't tell her. But remember that in the initial stages, when the family is also hit with the diagnosis, when they are also grappling with it, that's a time where if you tell them that it's our responsibility to do this job, they often hand it over to you. It's only when the wider family gets involved that don't tell becomes the rule. So I think always it's the primary physician's responsibility to convey the diagnosis. The other point of combining hope with honesty, actually, this has been shown in one of the papers of managing malignant brain tumors, that you have to acknowledge this tension within yourself to the patient and to the family. That we know that giving you too much detail may affect your hope, and but we also have to be honest to you. So, and they understand that you are, uh, in a sense, participating in the same difficult journey. Right. Anybody has anything else to ask on this patient before I move on to the next? So the other three cases, I mean, depending on how much time we have, the next is a Parkinson's. So after that is a dementia, and the last is a severe brain injury. Any questions? Any comments?
Sir, you told hospice care is not available for neurological diseases in India.
Yep. Yes.
Okay.
So if you look at hospices across India, they are all actually meant for cancer. So it is only malignant brain tumors amongst the neurological diseases who can be admitted to a hospice. Otherwise, for instance, if you have Parkinsonism or dementia, you can utilize their services for home care, but you cannot admit them to the hospices. Dr. Sunil Kumar, am I correct? I know Pallium has a different model, but I think this applies to practically everywhere else in the country.
Yeah, most of the hospices look after patients with cancer. Um, that's correct. But we have a lot of non-cancer patients too. Only 45% of our patients are having cancer, and the rest 55% of patients are having non-cancer diseases requiring palliative care.
But Dr. Sunil Kumar, you are Pallium India, and that is Kerala. The rest of the country, unfortunately, is very different.
Yeah, that's true. I agree.
Yeah, that's something that all of us should accept the realities of our situation. As we change, hopefully things will be better. And I know that provided the primary clinician is willing to uh, participate with the palliative care team, home care teams are willing to support our patients with hospice care at home. But on their own, I can understand they would be a little reluctant to take over neuropalliative care. Any other question? Otherwise, I'll move on to the next case. Okay. So, sorry, one more slide was left from this. This is part of the original paper that came out, which showed, as you can see, 5-year survival is practically zero in this particular type of patient. Right. So the next patient is this lady who's who's married, 2 children, lives with her husband in their own apartment in a suburban Mumbai. And she's generally pretty disciplined, exercise, yoga instructor. Her husband is older, and he also closed down his business, and they had both effectively retired. And their main job was taking care of their younger son's kids who lived next door. And they had an older daughter in the USA, and they just returned from a month there. And when she came in with a history of slowed movements, left-sided tremors, and constipation. And she was beginning to find it difficult to cook and look after the grandchildren, which was her passion. So, although she, of course, said, my daughter-in-law is like my own daughter, she does a very good job, but this is what I want to do. So, anyway, she was started on levodopa and had a good response. Now, just to tell you a little bit of Parkinsonism, we put this into the category of what we call movement disorders, neurological illnesses, movement disorders. You do have hyperkinetic, which means excess movement, and you've heard of dystonia, chorea, athetosis, tics, and so on. But you also have hypokinetic, and this actually is the bulk of what we see. The first and probably the biggest is idiopathic Parkinson's disease. And then you have something called atypical Parkinson's, which we'll not get into. Secondary Parkinson's is when it is due to strokes and so on. And other neurodegenerative illnesses may have Parkinsonian features as a component. Parkinson's disease is actually the second most common neurodegenerative disease, next only to Alzheimer's, and more than 1% of adults over the age of 60 years are affected. The etiology, of course, there is some amount of genetic predisposition, and we have to understand that. The essential criteria are slowness of movement, bradykinesia, or asymmetric rest tremor, the tremor in which, well, their arms are at ease and they start to show this tremor. Or there is rigidity, which is when you hold somebody's hand and rotate it, you can see that maybe the wrist at one side is not moving as smoothly as on the other side, and you can get partly because of the tremor, a superimposed cogwheel kind of feeling. The supportive criteria include a good response to levodopa. In fact, if you don't get a good response, then at least later on they may have motor fluctuations or levodopa-induced dyskinesia and so on. There are red flags, and we won't get into that, but most patients who have a slowness of movements, rest tremor, and respond to levodopa are idiopathic Parkinson's disease. We'll drop this slide. I think there's no point. And once Parkinson's disease starts off, it's a degenerative disease, so it gradually progresses. So in stage 0, typically neurologists would be able to pick up somebody like this when they literally come into the disease with just the beginning of it. So somewhere between here and here is where clinical skill also applies. But by stage 1, you can actually make out clear-cut what I told you, slowness on one side and tremors and rigidity. By stage 2, it's bilateral. By stage 3, they start having impairment in balance. And the way to check this is called the pull test. If you stand behind the patient, of course, you got to see that you are supported, and you give them a sharp tug so that you're basically pulling them towards you. Normally, a healthy adult will immediately recoil. I mean, it takes a great deal of strength if you want somebody to actually pull them back, and you have to warn them. But Parkinson's people cannot hold their balance, and this is positive. By about stage 4, they can walk unaided, but they're fairly significantly disabled, and the last stage is in the wheelchair. Now, about 50% live about 15 years from onset, and in young people, when the onset is in the 40s, they can live as long as 30 years. Earlier, we used to say that Parkinson's patients do not die of Parkinson's, they die with Parkinson's, but that is not really correct. 70% die due to complications directly related to Parkinson's disease. This is sepsis, respiratory failure and aspiration, and the wasting syndrome. They eat less and less and become thinner. And as Parkinson's progresses, a lot of other features start to come up. We've spoken about motor problems. The levodopa effect starts to fluctuate, and they eventually start to have involvement of the throat in the same way that the limbs are involved. But what we are often not aware of are what are termed the non-motor symptoms of Parkinson's. There's, in the early stages, it's psychological, then there's fatigue, pain, dysautonomia, which means autonomic features also predominate. And because it is neurodegenerative, it overlaps with dementia. Towards the end, most Parkinson's patients will have dementia. So at this stage, she joined a local Parkinsonism support group. And one of the problems with putting people with Parkinson's into a support groups is that they see the advanced cases and they find it difficult to handle. But she actually, the way she was a doer. So she became a volunteer, and she actually helped set up groups in the suburb near her own house. And by 2012 to 2014, the levodopa started to give problems. And one of the problems, little not too common, is that is as the levodopa effect fluctuates in the brain, people start to uh, have what are termed motor fluctuations. So they will become very slow, and then unpredictably or suddenly they will start literally dancing. And this can be very disconcerting. Even for the family, it is pretty difficult to watch. And this may also be associated with pain. But pain is only one part of it. The not non-motor symptoms of Parkinson's we now know, and this is very important for the palliative care because neurologists and movement disorder specialists are very good at handling the motor symptoms in terms of treatment, and we'll talk about other things that can also be done. But it is the non-motor symptoms that make for most of the disability and most of the trouble living with it for patients and families. Autonomic dysfunction is you can understand that will produce orthostatic hypotension. So when they stand up, their blood pressure falls. They may have bladder and sexual dysfunction, and they often have sialorrhea, which means they have excess saliva, and this is due to both uh, excess secretion as well as inability to swallow. So it all drips out, and that can be a very distressing symptom. Constipation is almost universal, and some patients can also develop gastroparesis. But probably, again, one of those things that we don't often realize is that there's a lot of pain in Parkinson's disease, uh, cramps, and general neuropathic pain, pain related to immobility. It's quite substantial. Uh, Sleep disturbances are known. We've already spoken about dementia, and they start to get psychiatric features also. All of this uh, can be very difficult, not just for the patient, but also for the caregiver. So when this is systematically assessed, people with Parkinson's disease report an average of 8 non-motor symptoms when you actually check this out. So at this stage, um, this was actually a little later. The family was introduced to the idea of deep brain stimulation. And because she was in the support group, she had seen patients who had had it, and she knew that at some stage she would have to undergo it. Now, when you start discussing, actually, I hadn't seen her at this stage. I mean, this was something that I spoke about to them a little later. Uh, Remember that we have to, at some stage, discuss goals of care. Now, goals of care, if you look at any part of medical care, we have essentially three goals. One is to enhance longevity, make people live as long as possible. The second is to enhance function. And the third is to enhance comfort, meaning to avoid suffering. And these play out into their values. So the values could be, if you say longevity, living as long as possible, not giving up. If it means function, it means maintaining independence. And if you're looking at comfort, then avoiding futile interventions. So you also have to see how these fit into their wishes at that particular stage in their life. And well, in addition to wishes, there are preferences, but people also think of these goals of care in terms of duties. So these could be spiritual, but it could also be avoiding becoming a burden. And you have to watch out for these statements. When you hear these statements, these are the ones that you have to uh, uh, explore with them to figure out what it is that is important to them. Because um, although we have these three goals of care, remember that there is a time when it is not possible to have all three. And you will have to choose one or two over the other. And these are choices that we have to explain to patients. So In fact, she did very well. She even restarted driving. And when she came back in February 2020, just before the pandemic, this was the first time that I met her, and uh, she came with her husband, and she was very happy that she had got the DBS. I'm watching my grandchildren grow. I am there when my grandson comes back from school, and I feed him something before he goes for cricket practice. Last week, I helped my granddaughter wear her first sari for her high school event. She has grown up so much. So, you know, when we look at suffering, we also have to be aware of the flip side of it. And the flip side of it is that we have to be not just aware, but we have to make room for joy in serious illness. And although it may seem that it does it may account for very trivial things. I mean, giving a snack to a grandson, I mean, what's the big deal about it? That's what one of us would say. But no, for that was a joy, the daily joy for her. And these joys can encompass multiple little things. Um, and effectively, when you bring out these topics, um, they are an incredibly powerful means of ensuring that patients living with serious illness feel seen and heard. Speaking about joy frees them from the role of patient. A patient is someone who's defined by illness to a person with choices of how they live. Joy promotes resilience, and it allows them to steal small victories from progressive, incurable, and otherwise insurmountable illnesses. So it's possible for us to explore these moments of joy and to kind of celebrate it with them. If anybody wants this article, please do write to me. I'll be happy to share it with you. Anyway, and then the pandemic began. So I ran into her son in the oncology section. Her husband was not doing well. He had developed metastatic gastric adenocarcinoma, and you can understand what a mess it was during those initial stages of the lockdown. They could only give palliative chemotherapy, and he developed COVID during hospitalization. Came back home with tracheostomy, Riles tube, came back to hospital. Eventually, he got to palliative care. And in fact, the elder daughter came from the US to help manage, and finally, he passed away at home in November 20. And the first statement that she made when I saw her after this had happened is, I don't want to die with tubes in me. So when she came in at this stage, she was obviously still grieving. This was March 2021. And she mentioned hallucinations. Now, hallucinations are delusions, hallucinations are often experiences that we have to explore. And these are pretty much after depression, very common in the neuropsychiatric problems that people with dementia and Parkinson's have. So her hallucinations were women who would come and talk to me. I know they are not there, but I chat with them. Then I tell them to go away when my grandchildren come in. So initially, hallucinations can be unformed. Then they start to become formed. And very often there is a certain amount of insight, but there is also a certain amount of comfort. It's only later that hallucinations start to become threatening. And at this stage, the mini mental was 21/30. 24 is the cutoff for dementia. So she had dementia, and she was already beginning to have issues with toilet control. And then in September 2021, she came in the emergency, and she was delirious. She was not recognizing family members. And this was surprising because this was so fast. She developed mild fever, leukocytosis, and it was only when she was catheterized that we realized what had happened. The urine bag had more than a liter, well over a liter of turbid urine, and we eventually put her in a silicone catheter. and eventually, because there was a good caregiver, we could change to clean intermittent catheterization. But now she was completely dependent, except for the eating. And it's important to identify this issue, which can come up almost throughout in palliative care. It's not often realized. We know that constipation and urinary retention can cause delirium, but in somebody who already has a vulnerable brain, this can be really, really tragic. And that is one of the reasons why, when in doubt, catheterize. But the other point to remember is that in individuals who have vulnerable brains, uh, a stay in the ICU, even if they're reasonably functioning, reduces their level of function, and they stay at the lower level of function until death. This, of course, can happen due to a kind of a brain injury in the younger people. But in older people, it could even be a systemic event like a hip fracture. You can understand when this happens because of brain injury, but how do you explain it when it happens because of something that doesn't cause direct brain injury? We believe this is because the occurrence of delirium is a marker, and perhaps part of the causation of rapid neurologic decline in people with vulnerable brains. The mechanisms are still not clearly understood, but it seems to be largely related to systemic inflammation. And this brings me to another point, which again is not specific to neurology, which probably overlaps with much of the rest of geriatric practice as well. And that is, how do you predict medium-term prognosis in older adults who are declining? And there are multiple risk scoring systems that you will have available. I find this probably the most useful. And again, if anybody is interested, I'm happy to share the papers on this. If you look at people who are over the age of 70 years, are admitted to hospital for acute illness, based on the information at discharge, you can stratify them into people who will pass away within 1 year and maybe survive longer. So what are these risk factors? The first is somebody whose activities of daily living are completely dependent, 5 points. A little less, say for instance, like our lady, I think she could eat. What did I say there? Yeah, she needed help for everything, but she could eat by herself. So if we look at basic activities of daily living, are 5. One is transfer from bed to chair. Then the second is toileting. Third is meaning continence and cleaning oneself. Third is bathing. Fourth is dressing, and fifth is eating. If somebody, and typically you'll find that eating by their own hand is probably the last one to go. But somebody whose 4 ADL are dependent, 2 points. And then you look at the other things that are wrong with them. Now, actually speaking, this lady was good in other respects. But if you have somebody who's developed comorbidities like kidney failure, or has a dropping albumin, or has malignancy, then you can see how these numbers pan out. And if somebody has, say for instance, you have an elderly male who's completely dependent and has a creatinine over 3, just this much, that individual's likelihood of mortality in the subsequent 1 year is over 60%, which means that individual, if you take 60%, a little over 65%, survives 1 year, apply the same figure next year, and the next year you can realize that these are individuals who will definitely pass away within 3 years. So Our Lady, well, she had a reasonably good likelihood of survival, but she was significantly disabled, and now she was getting a lot of pain. although she was demented, but she could complain about pain, and her dementia was, well, somewhere in the middle range. Um, Her husband had passed away. The son had not really been involved when the DBS had been done. And now came the question that her battery, the DBS battery, needed replacement. And that cost quite a bit. So this was what the son said. But the way it was, well, we knew that she was close to the end of life. But the question was that given her distressing symptoms, which were not controlled with medication, we suggested that the battery be replaced. But as it happened, they were still making up their mind when she actually came back, and we finally did put in a new battery. This was at about 2 or 3 months. And a little while after that, just after the battery was placed, she actually came back with aspiration. And this time she needed to be discharged with the Riles tube. And she had major problems. She needed to be restrained, kept pulling out the Riles tube. And then we had the fairly difficult conversation about how to manage at this point. And eventually, our palliative care physician was also involved, and the family had also begun to accept this. And I reminded them that she had actually told me that she did not want tubes placed inside her. So her Riles tube was removed, and she was swallowing with difficulty. But she was at home, and again the family came around, and she passed away at home. We had palliative care visiting her regularly, and you know what? Because of the expense that they had gone to, when I suggested that would they mind if we removed the battery for somebody else, they actually accepted it. Before the cremation, we actually our neurosurgeon went there and took the battery out, and well, I think it was reused with somebody else. So again, this case is where I stop. Jagruti is here, and she would remember that we've had a similar situation of Parkinson's patients where the family came to the point of removing the Riles tube and managing the patient.
Yes, sir. Yes, sir.
Would you want to say something quickly? A couple of minutes?
Yes. Family wanted to remove the Riles tube, but the daughter was little resistant. But ultimately, they took the decision of keeping the Riles tube and not feed anything through that. But ultimately, they removed, and we managed her with the
Sedation.
sir, yes, sedation. We gave midazolam subcutaneous, and then her journey ended peacefully, sir.
Yeah. So this is something that I think we all have to accept, that one is obviously, ideally, she should not have had the Riles tube, but sometimes these decisions get taken in an emergency and you have no choice. But if this discussion is something that has been ongoing, then this is something that can be tackled. Anybody else has any questions? Let me check out the chat. Apathy. Okay, so apathy is a fairly standard symptom. Unfortunately, it's a little difficult to quantify and assess, but you will often find it in patients with dementia. Because they have frontal lobe involvement, it actually becomes difficult for the family to see, because this is a patient who actually is doing everything else, but otherwise just sits in front of the TV, for instance, and does nothing more. And this can go on for years before the dementia is diagnosed. Any other question? Sorry, your voice, you're not audible.
So this DBS, changing the battery is a surgery again, no, sir?
So no, so the battery is under the skin on the chest wall, no? So under the shoulder. So it's a simple incision. You just take it out. One reason for doing that is, I mean, obviously, if it's an electric crematorium, it won't bother anybody. But in a wood crematorium, it explodes. So there's a reason for doing it also. Plus, the other thing is, this was just 4 months old. It still had a good 9 or 10 years of life. And the family
Did that
agreed.
help her, sir, after replacing the battery for the last 4 months of her life? Did it help her?
Yeah, the pain went down. No? Sorry, I didn't enter that. Yeah, the pain significantly went down.
Okay, sir.
It did help her. I mean, it was a difficult decision, but
Okay.
it did help her. I'll move on. I think I'm taking too much time, so I'm going to move a little faster. Okay. So the next is this lady who was at that time a practicing gynecologist, and in mid 2015 she came with her older sister. She was married to a general surgeon. They ran their own little hospital in a distant suburb, and she actually reduced her practice, had a junior working with her. She came in because she had memory problems, and this was confirmed by the sister. She was forgetting names, but at work she was managing to keep notes of everything. And when I asked, did a basic mental status examination, she could not remember the 3 words. So she had vascular risk factors. And when we did her basic test, her B12 was a little low. The MRI showed minor abnormalities, but the MMSE was actually above the cutoff for dementia. And I had a longish chat with her. She wanted to know what should I do and what should I not do, because I want to make this list because I'll forget. She wanted to know how to prevent progression, and her clear statement was, I don't want to be dependent. She had some life tasks which are not major because her family was in that sense settled. And again comes the question of palliative care at this stage. And again, I'm going to just put it out there that I believe that all of us, once, depend whatever the specialty we are in, once we diagnose a life-limiting illness with a basic bit of skill, our business is to begin the journey of palliative care there. Again, I forgot I had put this slide also here. Remember that there are only about 200 palliative care physicians all over India. And if you send a patient like this to specialist palliative care, it will undermine your own existing relationship. And you cannot do this because, again, care is going to get fragmented. So what are the skills that we require? And again, I'm not going to go into the details, but we need to be aware of basic management and basic discussions. And we need to involve specialty palliative care, which means say somebody who is exclusively practicing palliative care for refractory symptoms, complex depression, existential distress, conflicts within families, even between staff and families, and sometimes amongst the treatment teams, and then come in when it looks like cases are near futile. Can we tell her prognosis? I'm going to jump a little and not wait for you people to answer. Yes, we know that somebody like her has a significant risk of progressing to full dementia. Even though at this stage she's not got dementia, it will progress. So, in fact, she came back a month later alone and she wanted to talk about the prognosis. So, her son is an IT engineer settled in the US, and they had gone for the first grandchild. They came back. She had deliveries coming up, and the husband did not want to stay longer, and so on. And there was a bit of a problem. Her daughter had married out of caste, and her husband had problems there. So her real grief was the fact that I could not even attend my daughter's delivery. So I met her again in a local conference, and she remembered that that she would not remember my face. So he told her husband, and her husband actually brought her to me. And then the husband passed away suddenly. And the local neurologist, I was speaking about something else, and she told me that madam has slowed down, but she still does planned gynec surgeries. And then when she called for an appointment, I asked her to do a detailed neuropsych. So this time she came with the daughter. Hmm. The the daughter who had married out of caste, who was obviously her favorite child, and the daughter was in the mid-30s, mid-pregnancy, and madam had was definitely in dementia. And I actually delivered her the diagnosis because she remembered what we discussed. And here again, remember, you have to use for a difficult diagnosis like that, you have to do it systematically using the spikes protocol. So uh, I'm again going to point out that situations like this, the diagnosis is not enough. There are other items on the agenda here. And uh, those items on the agenda I'll discuss, and I'll tell you how these work out. Now, at this stage, the son came and stayed for about 2 months to clear up the parents' property. Uh, she had reconnected with the daughter. She was still sitting in the OPD. And in fact, her daughter was keeping a remote check on all of this. She said the assistant confirmed that it was a clean surgery. Now, when the patient is a doctor with dementia, this becomes, as you can understand, a pretty tricky issue. But there are other issues that come up for neurologists when somebody has dementia. You have to find out if they are driving, and if they're driving, then they and the family have to be warned to stop. As you can imagine, Alzheimer's disease in physicians is not yet. I think it is a noticeable issue, but it's a fairly big issue, for instance, in the United States. And for all of us, it's important to understand that probably the first thing is, if you see something, say something. Uh, if it is possible, if you have any role in this responsibility, then you have to uh, get them to do a basic workup and actually ease and improve the process of retirement. Though people, as in this lady, are known to work for some period of time after the onset of dementia, because there are basic skills that they can manage. So uh, at this visit, I discussed advanced care planning with her. And her first statement was, I don't want to be dependent. Again, can I opt for euthanasia? I said, no, it's not legal in India. Your daughter and I will both go to jail. So remember that euthanasia is although we have uh, validated advanced care directives, this issue keeps coming up in our discussion. In India, formal euthanasia, which means medical aid in dying, I can tell you that I would believe it's at least about 20 to 30 years away. And there are countries in the world where um, this is already possible. And in fact, in the Netherlands, at the beginning of dementia, people can actually ask for euthanasia at a certain period of time, depending on how they progress. So the other question that I asked her was whether she had made her regular estate will. Meaning splitting her property, because the husband had passed on and all the property now was in her name. The husband had made no will. So she had to do it. So the issue for me was whether I could certify her as fit to write and sign her will. Now, again, you will wonder, how is it that this also comes onto my plate? But I believe that when you practice neuropalliative care, then you are looking at a much wider range of responsibilities than regular neurologists are willing to take on. And it's important that if you are part of their journey, then you have to take part in whatever comes up on the way. And it's possible to do this systematically. I'm not going to go into the details here, except that for somebody who's above the cutoff, you can actually certify them that they can make their decisions. Once they have early dementia, then you have to actually examine them. It's once the MMSE drops below 16, then probably the only thing that they can do is identify their surrogates. I'll skip this, but there is a format for assessing decision-making capacity, even in dementia, even to the point of making a will. And this is something that I use. So she did make her estate will. And I asked her at this stage, this was still before we had our advanced care planning was in India was made easy recently. At this stage, it was still in the stage where you needed to get the magistrate to countersign it. But I told them to look up this document called 5 Wishes. If anybody of you is interested, you can just type 5 Wishes and you'll get a very complete advanced medical directive document, which is available for free download. And why is it so important here? Remember that advanced care planning is a process that supports adults at any age or stage of health in understanding and sharing their personal values, life goals, and preferences regarding future medical care. And probably the more important part of it is choosing and preparing another trusted person to make medical decisions. And that person also has to be prepared. That person has to understand what you would want, so that the patient receives medical care that is consistent with their values, goals, and preferences. This time, the next time that she came in was mid 2019. She came with the son. She had closed her practice. They were in the process of liquidating the real estate assets. She moved to a flat next to her daughter. And again, identifying joy, it was a new grandson. And by now, she was still able to do her basic activities of daily living. If you remember, moving around, bathing, toileting, everything was possible. But she could no longer choose her saris. So her saris and matching blouses would be set out by her daughter, and the daughter would also put the pillbox together, and her dementia had worsened. So we started her on treatment for this. And there comes the question of the prognosis of dementia. Now, the thing is that like Parkinson's disease, in these long neurological illnesses, people often forget that these are terminal illnesses. These are terminal illnesses from which people will die. And we now know that when somebody has dementia, this is clinical dementia, this is at a stage where this becomes functionally very significant. A lot of damage, a lot of neuropathology has already occurred. And of course, dementia can progress very, very slowly. Stage 1, that is the stage where she was initially 1 to 4 years. Dependence worsening is can be as long as 10 years. And stage 3, actually the terminal stage where they're completely dependent and even bedridden, can be as long as 12 years. And to my knowledge, this longest stage occurs when they get artificial feeding. So in March 2020, just before the pandemic, she came with the son-in-law. She was now using a salwar kameez, occasionally incontinent. They took her to the USA, but she was very confused. In fact, on the flight, she insisted on paying the flight person, the conductor, for her ticket. And the family thought that the rivastigmine, the medications we had given, had not really helped. So we were considering deprescribing. I'm going to jump this. So there's been one more visit in December 22, but last year she came in accompanied by son and daughter, already in a wheelchair, few words, basic activities assisted, but she did say my name, and surprising the children. and she had had a good pandemic. And in fact, her children came back after this visit to discuss end of life planning. And at this point, we all agreed that she would never get a rice tube. The last contact was in December, and she's still stable. So remember that eating or swallowing difficulties are often a problem towards the end of life. If it is an emergency, you have to figure out if dementia is a cause of eating or swallowing difficulties. And if it is, then you really have to focus on comfort feeding. If it is not dementia, then you may do a a trial of nasogastric feeding and see if that helps, or otherwise move to comfort feeding. There is enough evidence now that hand feeding or comfort feeding is the route to go in advanced dementia. And again, this document is free on the net if anybody wants to look this up. Contrast this, if you remember, in the last lecture, I showed you a case of motor neuron disease where we put in a peg very early. So this becomes almost like a dichotomy in people who have motor problems, movement problems, where eventually it is affecting swallowing, but they are mentally intact. The peg gives them up to about 6 months, maybe even a year of extra life because it avoids aspiration. On the contrary, when somebody with dementia, cognitive impairment, reaches the end of life, then quality of life has gone by the time they are unable to swallow, and it is definitely rice tubes can be avoided. Again, the same slide. So, and at this stage, then you have to figure out what is the basic routine care. I'll leave that aside. So, a quick discussion of this case before I move on to the last. Dr. Sunil, do I have time? I can discuss one short case.
Yeah.
Okay. So, any questions here? What is there? Okay.
So
yeah,
you said,
Dr. Puneet.
so you said that towards the end of life, comfort feeding is enough. What if they're not able to swallow and they aspirate?
So typically, this is exactly what happens. It really is the end of life. And even putting in a rice tube at this stage actually does not, if you look at the paper that I put up, the incidence of aspiration does not go down significantly with rice tube. In fact, because patients often tend to be, and relatives tend to overfeed and it's a little difficult to stop them, they regurgitate. So the incidence of aspiration does not go down. It's actually fluid management, but then they often do get bloated. And typically, if somebody has a rice tube at that stage, then, and of course, if great care is taken, you'll end up with somebody who's in the vegetative state and with a rice tube. It's a difficult conversation with families. Sometimes it can be extremely challenging, but if the family is on board, then it usually goes through fairly smoothly.
One thing what I have seen is that feeding is more of a cultural kind of thing.
Absolutely.
So the solace for the family that the patient is not kept starving is very important. So if even at that stage, if the life gets prolonged beyond a certain reasonable period of time, like I had a patient who was starving for 3 weeks. He was skin and bones, but he was still alive. And at first the wife was refusing to put in the NGD, and then she said, "No, I need to put in the NGD because I don't want him to starve to death." It was in fact too late. I mean, I knew that nothing would happen, nothing would change. But for her sake, I did put the NGT, and she fed him for another 1.5 weeks, and he passed away peacefully, but she was very happy that she didn't stop to death in the end.
So one of the things is that if palliative care is involved, this is the stage where we might want to look at sedation. And typically, culturally, because it's important to feed, you will see that little small morsels will still keep going in. Mouthfuls of water will still go in. The mouth can be wetted, but the family has to be helped through that period.
Yeah. Sometimes it's very difficult to arrive at
It
that
is.
decision.
So the important thing is that if palliative care, or at least the neurologist is aware of this, then this is a conversation that has happened months before, literally months before. Right. So it's our responsibility also to make sure that this conversation happens. Of course, there are instances where the family insists on putting in the rice tube and managing, but in my experience, even when they do so, it within a couple of months or 3 or 4 months, they come back and they understand then the futility of it. Right. So last case, and this I'll go through a little quickly. So this is the case of a 20-year-old girl who lived in a Mumbai suburb, and she had a road traffic accident. In fact, she was tossed by a speeding car, fell head first. She was in the local hospital in 30 minutes, and there was absolutely nothing. Her neck, chest, everything was okay, except that the brain was badly damaged. In fact, within hours, she needed to be intubated for airway protection. But she was rapidly declining. They gave her mannitol, transferred her to us, and by the time she came in, she already had a GCS of 6. And the neurosurgeon, in fact, was wondering whether he should be starting intracranial pressure monitoring, but then he realized that she was already beginning to decerebrate. And at 12 noon, a repeat CT head showed massive edema. This is This is not the first, the second scan. This is the first scan. The second scan was horrible. And there was a discussion with the family. A prognosis explained, as he said to the family. If you'd like to tell me how do you think this ends? I mean, obviously we are discussing palliative care, but even then, if you know what the prognosis of this is likely to be. Remember that this was a patient who was beginning to herniate. Now, if you look at herniation, whenever the brain swells up, it can either swell up on one side and we get what is called as uncal herniation, which is where the pupil on the same side dilates and then the brainstem is compressed on the same side, right? And regardless of that, you can start getting what is termed as decorticate and then decerebrate processing. If it is central herniation, right directly down, you will get largely symmetrical findings. And herniation, remember, it displaces, distorts, damages, and eventually destroys the brainstem. As soon as the brainstem starts to get compressed, consciousness is lost. And if it is long enough, we believe that if this state persists for longer than a few hours, then it causes permanent neurologic morbidity. And if you leave it, then it eventually becomes brain death. I think I've shown you this slide during the last lecture, so we'll skip it. There is a salvage procedure for this. And this is a salvage procedure that has now been used more and more often in the past 20 years. It's called decompressive hemicraniectomy. You remove a huge flap of skull. And once you do that, the brain has the space to expand. The problem is that when you do this, you decrease mortality, but you give an survivors with severe neurologic incapacity. There are some situations in which it helps. For instance, if it is done for an infarct in a younger patient at an early stage, you actually have significant recovery. But when it is done for traumatic brain injury and for intracerebral hemorrhage, these people will continue to have neurologic morbidity. And the point is, how do you make these decisions? So somebody actually took the opinions of Swedish healthcare personnel regarding acceptable outcome for decompressive hemicraniectomy. And nobody was willing to get a hemicraniectomy if they thought that their outcomes would be would be bad. So there are these ethical problems that for many of the participants, the most likely neurologic outcome would be deemed unacceptable. So we need a broader societal discussion regarding the value of a procedure that converts death into survival with severe disability. All the more important for us. Now, how do you explain all of this to the family in that period of time in the emergency? Not very easy. So what I usually suggest is that if you have the time, then you have to prognosticate individually. You have to consider patient-specific factors and so on. But regardless of what you do, remember that this formulating of prognosis can, of course, become self-fulfilling. If you say that this is going to be bad and withdraw at that point, then it is, well, obviously you have determined the prognosis. The second is, it's a little difficult for us to predict future quality of life because we see this point and we think that it is going to be bad. But people with severe disabilities report better quality of life than when well people are asked to imagine similar circumstances. And we call this the disability paradox. Healthy people focus on what changes or is lost, while devaluing those aspects of life, like relationships, which really remain unchanged. And we call that the focusing illusion. So as people move into life with disability, baselines change and new meaning and new value emerges. So that is something that we have to keep in mind. So when you have this kind of a prognostic discussion, you first, of course, you have to figure out who you're having it with. Obviously, in neurology, it's typically surrogates. Sometimes the problem is that the providers, the doctors may be multiple, so you have to be sure that this is consistent. What you have to answer is how long and how well. In a situation like this, the most important question is how well will this patient be? And that's sometimes more qualitative than quantitative. Ideally, you should do it as soon as possible, but in acute neurologic emergencies, the family meeting, which is a core competence for intensivists and perhaps also for neurologists and neurosurgeons, has to be held within 72 hours. In this situation, obviously, it had to be held within the first 6 hours. Remember that when you're communicating prognosis, families have no clue about what you're talking. And for them, they've heard of miracles. They think of people are going to recover well. So you have to be very clear about that. They want prognostication done with compassion. Whatever they decide, they want their decision to be accepted, even though you may not agree with it. Remember that uncertainty is frustrating. They need explicitness. They often want numeric estimates. Whereas from our side, we live with uncertainty. We are very comfortable with uncertainty. And we don't like making very clear-cut predictions. But there are situations where you have to. So when we communicate prognosis in these situations, we usually prefer to put it in best case versus worst case. Typically, definite statements are only for, say, something like brain death or say, so-and-so will never be normal again. The one thing that we realize is that traumatic brain injury in younger patients is one of the most uncertain situations, and you have to manage that uncertainty. So my idea that what we could have said is that best case, uh, although even at that stage I wasn't very sure, but I thought that with decompression, maybe she would be able to walk with support, but she would be dependent. Worst case, might not leave the hospital. And my guess in between was that she will be bedridden, but will recognize and respond to family. Even though she was young, the magnitude of brain injury was too much. So, uh, and as you can imagine, the family's only statement was do anything to save her life. And she got uh, the maximum decompressive brainectomy, meaning this whole bit was removed. But literally, as she went in, she had already become flat. GCS3 is, well, if it persists, it's brain death. So she developed hypotension. But after it was over, she was sedated, paralyzed, and then inotropes came out. Sedation was removed, but she was flat. And this was the stage where the next family meeting was taking place. And this was where I was also involved. And remember that when you have catastrophic brain injury, there's a final common pathway. Massive increase in intracranial pressure compromises the circulation, causes further anoxic injury, and eventually the cerebral circulation just closes. And this is anterior to posterior progression with finally loss of brainstem reflexes. The last is the loss of the respiratory drive. So when somebody loses respiratory drive, effectively the rest of the brain is gone. How long do you wait to confirm this? Well, for instance, with hypoxic ischemic encephalopathy, one would wait for about 24 hours because things can change. But in a situation like this, where you know what the injury is and how much, as soon as you identify it, it it is there. And so when you are diagnosing brain death, you have to have a known cause of catastrophic brain injury. You have to make sure that confounders have been ruled out. And here, like sedatives and so on. But here, for instance, they waited until after the sedatives are off, and you need a clinical exam to confirm coma. And finally, the apnea test confirms loss of respiratory drive. If anybody is interested, this is available free on the net. And the most uh, significant test is the apnea test. Remember, there's been a fair amount of discussion whether the apnea test needs consent to perform. But worldwide, the understanding, medical legal understanding is that it is actually a clinical test. And families, you need not ask for consent. Though I think in most situations, people would at least discuss with the family before doing it. It's important because if it is clear cut, it cuts short all confusion. Remember that when somebody, at least of a younger age, is brain dead, for the family, they will see somebody maybe on the ventilator, but who otherwise looks like they're just asleep. And there is a story of a boy who had brain death at the age of 4, and the family kept him on the ventilator. This of course paper was at 1998, but he finally passed away after another, I think, 15 odd years. And by then he had actually grown up, except that there was nothing inside his cranial cavity. So if brain death is diagnosed appropriately using what are termed the AN criteria, nobody has recovery of neurologic function after that. And remember that regardless of whether organ donation is possible or not possible or refused, we are now moving towards the stage where if somebody is diagnosed with brain death, it's important to remove the ventilator. Especially, it's going to be important if you are a steward of scarce resources, so a government ICU, or if insurance is paying, because, well, we'll get caught in between. So this girl apparently had this kind of discussion with the family, and the family agreed to organ donation. So again, I'm going to stop at this point. I think we have maybe a few minutes for maybe a minute for any questions. Uh, Again, the point of showing you these cases was to show you the range of what I believe neuropalliative care entails, the kind of range of decisions and the scope of what we can do, provided we are aware of our responsibilities. Questions? Yes, Dr. Raina.
Good evening, sir.
Bolo.
Sir, I had a question regarding the RTA cases called leading to cervical injury, and that leads to quadriparesis. Especially in young patients, it gets very tough to provide hope to the patient's family as well as the patient, because patient is fully aware that he's not able to move his limbs. What you have to say regarding these patients? What is the demand that they don't want to be dependent and they want to go for euthanasia? How will you manage palliative care in such scenarios?
So, if you realize, again, this brings me back to that point that I explained. When this happens right in the beginning, and obviously it depends on how severe the paralysis is. Somebody is paralyzed to the point that they are on the ventilator. Things are different from when they are where they are paralyzed lower and lower down. And again, this brings us back to the disability paradox. After they survive, after they have lived for a period of time, depending on how care is organized, their idea of quality of life changes, because their baseline and their expectations begin to come close together. So people have a poor quality of life when there is a major gap between expectations and reality. Once expectations and reality come closer together, actually quality of life tends to improve. Little difficult to understand, but this is something that has been documented even in spinal cord injury. And it really depends on the kind of social support that you have. So if you look it up, there are papers about elite athletes who've had these kind of injuries and who do have, well, quality of life of a kind. So I understand that in our situation, sometimes it may be very difficult, but I think it's important for us to keep engaging with the patient and make sure that physical symptoms are controlled, and well, take this conversation further. At this moment, I think, again, there is a fairly major discussion. I'm not sure if it is part of your course, though of course it is part of the International Neuropalliative Care courses. How do you address requests for assisted dying? Because in palliative care, we believe that assisted death is a failure. Dr. Sunil?
Yeah. So decision assisted suicide, that is something not legal in India. So what we need to tell the patient is, we will help you as much as possible to reduce your suffering. So essentially, as it is not legal in India, we may not be able to do that. But at the same time, you should be able to help the patient in some way to reduce the suffering.
Again, if anybody is interested, there's a fair amount of literature on how to live life with spinal cord injury. And again, we are not generally aware of it, but this is something that you can access and pass on.
Okay, sir. Thank you.
Sir, this rivastigmine patches are available in India, sir.
Yes, routinely.
They are prescribed for dementia patients or for.
Of course.
Okay. Okay, sir.
I routinely use them, and typically earlier I used to use tablets, but now more often I use patches. Most patients find them easier. They're a little more expensive, obviously, but where patients can afford it, I do use it. And typically, after starting it at about 3 months or so, make an assessment whether the family feels they have been useful or not. If they are useful, then you continue. If they are not, then you withdraw.
Do they give any pain relief also, sir? These
No, nothing. They're very good for bringing delirium under control. If you have a patient who has dementia and lands up in delirium untreated, then this helps quite a bit.
Okay. So post-stroke Parkinson's and such people can have this. Can we give this patch for them?
You can try it out, but it works best in straightforward Alzheimer's and Parkinson's, Alzheimer's.
Okay.
So can it be useful in patients who are agitated?
So typically, if say somebody is not treated, yeah, I'll just stop sharing also. Yeah. So if somebody is not treated and we make a diagnosis of delirium with on a background of dementia, you have to understand that dementia is chronic brain failure and delirium is acute on chronic brain failure, right? So when you see this kind of a situation, you may need to control the delirium with small doses of haloperidol. Remember that you have to make sure that the patient doesn't have any evidence of Parkinsonian features, because you can rapidly worsen them if you use haloperidol. But if they don't, and a good proportion of don't, you can use small doses of haloperidol and simultaneously start the rivastigmine patch, and they do quite well. Right. I've given them too much neurology. I hope it's not.
Sir, you always tell like how long, how well, and another thing you
Yes.
use. What is that?
How long and how well?
How long?
Yeah. So I mean, that's that. Those are the two questions that people want answered.
Okay.
How long and how well? And more importantly, it's a way of framing our thoughts about prognosis. Because until you are not clear, how can you be? I mean, you have to be willing to acknowledge uncertainty also, but you have to frame it in some way.
Okay.
Right?
We have got many quotations from you, sir.
Sure. You finish this and then maybe, but I'm quite surprised, huh? The Jagruti is doing both courses simultaneously, huh? And so also is Gajasraj, yeah.
Yes.
Good.
Trying,
Okay.
sir.
Good, very good.
Okay, so today we heard about 4 scenarios regarding the CNS malignancies, dementia, then catastrophic brain injury, and
Parkinson.
which one?
Parkinson, sir.
Yeah. So each and every patient is different from other patient, and depending on the disease condition, our decisions may also need to be changed. If a patient with motor neuron disease requires rescue, it might be beneficial, but a patient with advanced dementia, then it may not be beneficial. Because there is no evidence to say that it improves quality of life or it reduces aspiration, etc. in dementia. So, so there are a lot of things which we need to learn from this two talks on the role of palliative care in neurological diseases. And all of you, as as you have got some quotes also from Dr. Roop, you will use it. You are going to use it frequently. So thank you, Dr. Roop, for
You're
this
welcome.
palliative care in neurological diseases. And thank you, everybody. It's our first review.
Thank you. Thank you, Dr.
Right.
I believe you should start copywriting your quotes because, like Dr.
No.
Punita was saying, people will be using it extensively to make the palliative medicine, especially the neurology, reach masses. So maybe we can think about copywriting that as well. Thank you so much for joining us. We do
Thank you.
understand you would have had a very extensive day.
Yeah.
Thank you so much for joining us, sir, and enlightening us. And we do really, really look forward to have more such interactive sessions with you in future as well. Thank you everyone for joining in. See you in the
Good
next
night.
session. Till then, everyone take it. Bye-bye.
Good night.